So my name is Catherine Fornili, and I'm an assistant professor at the University of Maryland School of Nursing. And I've been involved in SBIRT since the first round of SAMHSA SBIRT project in 2003, when I worked for the State of Virginia Office of Substance Abuse Services. And I've been a program consultant off and on since then in SBIRT. I have no conflicts of interest to declare, but I have to say, I've got to move it up, that I'm very excited today to be speaking to you about a model that I have tried to develop that is a more recovery-oriented model for SBIRT. I call it SBIRT Plus Recovery Management. And there's no better time to share it with you than the month of September, which is Recovery Month. So I'm wishing all of you a happy September Recovery Month. Today, I'm introducing to you the integration of recovery management principles into what I tend to call traditional SBIRT. So in 1990, the Institute of Medicine released its landmark report, Broadening the Base of Treatment for Alcohol Problems, and it called for improved screening and detection for alcohol use disorders and recommended chronic care as opposed to acute care for people with alcohol problems. And it recommended interventions in community-based settings as opposed to the specialty addiction treatment system. And the report recommended that people with low to moderate risk, alcohol risk, receive brief interventions in primary care, and that people with moderate to high risk be referred to the specialty addictions treatment services system. So it's been more than 40 years of evidence in support of SBIRT, but SBIRT still remains underutilized in primary care. This is the 5th decade of evidence for SBIRT. SBIRT has been endorsed by the National Institute on Drug Abuse, the Joint Commission, which is an independent not-for-profit organization that accredits and certifies more than 20,000 healthcare organizations and programs in the United States. And the Joint Commission endorsement is and accreditation and certification is recognized nationwide as a symbol of quality. Also in 2014, the National Quality Forum endorsed SBIRT and alcohol screening. And the National Quality Forum is a not-for-profit, nonpartisan, membership-based organization that works to catalyze improvements in healthcare. The National Quality Forum convenes working groups to foster quality improvement in both the private and public sector, and it endorses consensus standards for performance and measurement. NQF endorsement is considered a gold standard for healthcare quality in the United States. So while we were trying to get SBIRT implemented in its 5th decade of evidence, there were what some of us refer to as those 2 studies in JAMA, the one by Sates et al. And the one by Roy Byrne et al. And those 2 articles kind of set the SBIRT world in a tizzy because they stated that brief interventions were not effective for decreasing drug use among primary care patients identified through screening, and said that widespread adoption of screening and brief intervention for drug use was not warranted. So originally developed for alcohol, but SBIRT projects have been modified over the years to also screen for drug use. In this year, Cambridge and States updated their recommendations about brief interventions, calling for us to rethink how we consider brief interventions. They called for stronger scrutiny of the evidence, especially around discussion content and counseling micro skills and the extent to which they were associated with improved outcomes. They recommended that alcohol screening not be isolated from screening for other risk behaviors and mental health questions. They called for more clarity about the unmet needs of people with alcohol problems. And they recommended that the guiding principle for brief interventions be the reduction of substance use and consequences, but not defined by the length of time of the brief intervention or the number of sessions that the patient receives. So I have examined the literature around SBIRT, breaking it into its various component parts, and looking at the various component parts as to whether there's evidence in the literature for their use with alcohol misuse, which would be drinking in excess, frequency and quantity, alcohol dependence, drug use, and drug dependence. So for all of the various screening instruments, there's strong evidence that screening is effective at identifying alcohol misuse, alcohol dependence, drug use, and drug dependence. But there's many unanswered questions about the efficacy of brief intervention outside of its use with alcohol misuse. So the literature is either mixed or absent about the efficacy of brief interventions for alcohol dependence, drug use, and drug dependence. And it kind of makes sense, because why would we expect the lowest intensity service that we have to work for people with the greatest problem severity? Why would we expect that a single brief intervention lasting 5 or 10 minutes would completely fix people with the more serious drug dependence and alcohol dependence? And I attribute Dr. Dawn Lindsay from IRETA for kind of opening my eyes to this concept, that referral is the least studied component of all of the component parts of SBIRT. We really don't know what happens when people are referred for treatment for any of those conditions. We don't know what kind of referral they get, et cetera. So we do know, though, that treatment is effective. And we know that treatment can be effective for both alcohol misuse, alcohol dependence, drug use, and drug dependence. So what is it about, why is evaluation of SBIRT so tricky? It's because it has so many different moving parts. And that makes it a pain to evaluate. So when you're looking at whether SBIRT has been found to be effective, in terms of screening, you have to ask yourself, which population, which substances, what frequency and quantity, what their problem severity is, whether the screening program was universal or targeted screening, who performed it, in what setting, with which instrument, how many times, and what the validity and the reliability of the instruments are. In terms of brief intervention, you need to know how many sessions they had, how long were they, how frequent they were, what duration was it. And in terms of referrals, you have to know, like, how were the referrals conducted? Was treatment even available? And that's one of the biggest barriers to implementing SBIRT, is that if there's no treatment to refer them to, people are hesitant to screen them. You wouldn't screen for cervical cancer or breast cancer and not have a place to send them if the test was positive. So it's really critical that people who implement SBIRT develop strong referral relationships for community-based treatment. And if they're not able to do that, that could be one of the factors that makes SBIRT so difficult to evaluate and outcomes be questionable. And so even if there was a treatment slot, were patients able to access it? And then there's also the concept of assessment reactivity in the usual care group. So when you're measuring a behavior, that behavior changes even if there's no attempt made to change it. So if you're asked reasonably detailed questions about how much you drink over what period of time, you're likely to decrease your consumption than you would if you had not been asked that. And so as a result, the control groups in brief intervention studies consistently show decreases in alcohol consumption as well. And so when both groups end up reducing their drinking, and we don't see enough difference in the drinking rates or quantity between the two groups, makes it difficult to show a statistically significant change as a result of the intervention. And we might conclude that the intervention was not efficacious, it didn't help reduce drinking, when it's because of this assessment reactivity. So regardless, a lot of us agree that additional research is needed before we can address some of the, not so recent now, the criticisms about SBIRT. And all of this makes outcome measurement very tricky with SBIRT, but as the saying goes, absence of evidence is not evidence of absence. So being a nurse educator, I wanted to address this clinical practice problem using an evaluation of middle range theory. Middle range theories help to conceptualize clinical problems and outcomes and help delineate effective interventions and methods of outcome measurement. So I utilized Smith and Lear's evaluation framework for middle range theory. And I looked at the, this framework calls for you to look at each of the theories associated with SBIRT as according to its substantive foundations, its structural integrity, and its functional adequacy. So substantive foundations require that a theory provide a substantive description, explanation, or interpretation of a named phenomenon with origins rooted in practice and research experience. The structural integrity requires that the theory's concepts be clearly defined, operationalized, and measured, and logically represented within a model. And functional adequacy calls for evaluation of the theory's applicability to a variety of practice environments and clinical groups or client groups. So anybody who's been working in SBIRT for a period of time is familiar with Wagner's chronic care model. It featured prominently in early SBIRT literature, and I chose to compare Wagner's chronic care model within the context of SBIRT with William White's recovery management model, which is a component of the ecology of addiction recovery model adapted from Bronfenbrenner's ecologic framework model. So if you look into the literature for the chronic care model, you find that it is associated, and you know, this is part of the recommendation from the IOM report that alcohol be addressed as a chronic condition in community-based settings, not in the specialty sector. So it made sense at the time to utilize Wagner's chronic care model to explain and evaluate and examine SBIRT. When I looked at the chronic care model using the middle range theory evaluation, I found that CCM is associated with changes in provider expertise and skill, patient education and support, team-based care delivery, and better use of information systems. But the chronic care model really didn't articulate how it can be used to improve substance use disorder outcomes specifically. The recovery management model, on the other hand, though, did specifically address the needs of individuals with substance use disorders, their families, and their communities. And in my opinion, it outperforms the chronic care model in terms of describing, explaining, interpreting the phenomenon of interest that I wanted to focus on, which is recovery. So I looked at SAMHSA's working definition of recovery, defined as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And at the time, SAMHSA 2014, SAMHSA was focusing on 4 core recovery measures: health, which is overcoming or managing the disease process, and physical and emotional well-being; home, which means that the person with a substance use disorder has a stable and safe place to live; purpose, meaning that they have meaningful daily activities like job or school or parenting; and community, and that's their relationships and social networks that provide support, friendship, love, and hope. Note that the focus in recovery is not on the word abstinence, but rather on improvement in the individual's health and having a place to live and a purpose in their life, not just on abstinence from substance use. So this is the model that I have developed, the SBIRT Plus recovery management model. Let me introduce you to this. I know it's a busy slide, but don't try to study this diagram in great detail right now. I'm going to break it down into its individual component parts and then build it back again for you, one slide at a time, and it'll make more sense as we go further along. But my purpose of developing this model was to try to articulate where what I call traditional SBIRT is situated conceptually within this model, and where I believe that the breakdown is within the traditional SBIRT model of care in terms of achieving positive outcomes at all levels of substance use disorder problem severity: the people with alcohol misuse, the people with alcohol dependence, the people with drug use, and the people with drug dependence. So finally, I'm going to use this model to address some of the well, some of, but not all, of the components of recovery management. I'm going to focus on 4 of them. And hopefully, I'll demonstrate how adding a recovery management focus to traditional SBIRT models can lead to improvements in patient outcomes and greater advances in the management of substance use disorders in primary care settings. So these are the 4 recovery management concepts that I believe are critical to this analysis. In this model, these 4 concepts represent a philosophy of organizing addiction treatment and recovery support to enhance pre-recovery engagement, recovery initiation, long-term recovery maintenance, and the quality of personal and family life in long-term recovery. First, let's look at pre-recovery identification and engagement. So the red boxes in this model represent recovery management. And the first one, pre-recovery identification and engagement, according to William White's model, recovery management model, this one refers to early screening and identification of individuals with drug use problems or alcohol use problems. And the word engagement is important because that refers to the forming of a therapeutic alliance between the practitioner and the individual. And it's at this point of the dance between the clinician and the patient in community-based settings or any setting really, specialty addictions treatment or primary care and other settings, but I'm talking primarily about primary care right here. So it's at this stage of the recovery management process where the therapeutic alliance needs to be formed so that the practitioner has an awareness that there's a window of opportunity to intervene with this patient. But that's not enough. The individual has to have an awareness that the primary care provider is helpful and supportive. That should say provider. So pre-recovery identification and engagement occurs typically in non-specialized community-based settings. The next recovery management concept is recovery initiation and stabilization. So in terms of traditional primary care SBIRT programs, this step begins with either a brief intervention, when the brief intervention has been provided or the referral to treatment has been provided. And really the referral to treatment is like a brief intervention with a different purpose, referral, as opposed to a brief intervention for people with lower risk problems. The brief intervention is intended to reduce use and consequences. So recovery initiation begins either when they've gotten a brief intervention or a referral brief intervention. Typically, the field, the healthcare has viewed the patient's failure to initiate and stabilize recovery as a personal failure of the individual. It's considered non-compliance on the individual's part rather than flaws in the design or execution of the referral protocol. In the context of primary care SBIRT, stabilization, at least for individuals with serious substance use disorders, is something that occurs within the context of the specialty addiction treatment system, not in the primary care setting. So just like we encourage primary care providers to screen, identify, maybe diagnose, and refer people for specialty diagnosis and specialty treatment, the same thing applies to the primary care provider's role with individuals that have substance use disorders. Primary care providers refer their patients to cardiology, endocrinology, orthopedics, lots of different specialties. Typically, it's treated differently than the referral to treatment for substance use disorders because we know that sometimes primary care providers don't necessarily see management of substance use disorders as being within their purview, and some studies even show that they really don't like patients with substance use disorders. So the next concept within recovery management model is sustained recovery support. And the emphasis in this concept is on the word sustained. It's one thing to give somebody a card and say, here, go get some treatment and come back when you're all better. And it's a different thing altogether to help sustain recovery support with an individual before treatment, during treatment, or in lieu of treatment. So these recovery support services are non-clinical services designed to assist individuals and families working towards recovery. And they incorporate a full continuum of services to foster recovery by reducing or eliminating environmental or personal barriers to recovery. They include services like child care, transportation, housing, life skills, employment readiness, legal consultation, wellness checkups, and self-management support. So when recovery support services are provided by professionals like primary care providers, as well as family members and peers in recovery, the patient receives support in all of their life domains in a variety of community-based treatment or other settings, and they're best delivered over a sustained period of time. One more slide, and then I'll stop for questions. So the last concept within the recovery management model is long-term recovery maintenance. most addiction treatment services are institution-based, and the service providers in substance use disorder treatment specialty settings have little contact with the natural environments of the individuals and the families that receive those services. Long-term recovery maintenance involves shifting the focus from the service environment to the natural environment of the client. And patients with substance use disorders and their families benefit from extended post-treatment monitoring and support to help sustain the benefits of treatment that they received. In a recovery-oriented chronic care model, care goes from an acute care model, which treats medical conditions in an intensive, short-term, episodic manner, to a chronic care approach, much like suggested by Wagner's chronic care model, but it reflects a service commitment to long-term supports and wellness for the types of problems that people with substance use disorders have. In this phase of the model, care goes beyond cyclical crisis intervention, symptom suppression, and reduced hospitalization to a sustained recovery enhancement and recovery management focus. And the role of the primary care provider at this point is to train clients or patients on self-care, provide post-treatment checkups. How's it going? You know, how did it go when you went to that appointment? Did they put you on any medicine? Can I help you with your service plan? And it involves the primary care provider helping the patient with community resources to support sustained recovery. So this is a good spot to stop for a second and ask if anybody has any questions.
All right, Dr. Fornili, we did have two folks that sent questions in. So the first one that we had, this is from Jerry. They said, isn't most of the success of SBIRT with non-dependent patients who don't need to be abstinent and therefore need to get into recovery?
Well, it depends on whether you define recovery as being focused on abstinence or being focused on numerous domains of recovery. You know, I think I mentioned the four focus areas of recovery: home, social support, a purpose in life, and I like to use SAMHSA's 8 dimensions of recovery model, because you can have somebody who's abstinent from using alcohol and drugs, and the whole rest of their life is in disarray. Or you could have somebody who might use a little bit of substances, but they're making positive changes in their life. They're going to school, they're working, they're rebuilding relationships with their family, they're taking care of their health issues. They didn't even know they had health issues until they stopped using substances. They're not getting any younger, so they have all of the same chronic care illnesses that any primary care patient would have for that age group, whichever age group they're in. So can you repeat the question one more time, make sure I focused exactly on the point the caller was making?
Right, sure. So isn't most of the success of SBIRT with non-dependent patients who don't need to be abstinent and therefore need to get into recovery?
Like any other thing in primary care, specialty care, or behavioral health care, the assessment needs to be individualized and the treatment plan needs to be individualized. And whereas none of us would encourage non-abstinence, you know, I mean, we would love to see abstinence from substance use. But it's how it all fits together within the rest of the context of their life. I'd rather have somebody not neglecting their child, beating their wife, getting arrested, or driving drunk. You know, I'd rather them deal with that than deal with the fact that they feel like they're not in recovery because they drank last weekend. or, you know, they've given up some drugs, but they continue to use some other drug. I'd love to have abstinence, but in the absence of evidence, in the absence of complete substance remission, all the other areas of their life are so critical. And let me think, there's one more, I forget the other point I wanted to make about that, but did that help? The reader could maybe write back. And you had one more question?
Yeah, actually there have been a couple more that have come in. So the next one is, I work in a primary care setting with providers who will be implementing SBIRT. Public health officials in the state, our funders, hosted a psychiatrist speaking about the treatment of tobacco dependence, implying that they should take an abstinence approach for tobacco. How would you suggest addressing traditional SUD treatment providers who uphold an abstinence-only approach when we're meeting patients where they are at and working to offer a continuum of recovery support services?
That stimulated me to remember the point I wanted to make for the last caller, too. That they said that that isn't SBIRT better for non-dependent people who might not completely become abstinent of substance use. I think when you're trying to make people change behaviors, sometimes a complete change is overwhelming and can make people shut down and give up. And so I love the research that the Mid-Atlantic ATTC had back in 2001, I think, that talks about part of the best predictors of outcome, positive outcomes, are not the model that we use or the, you know, it doesn't matter whether it's outpatient or inpatient, residential, MAT, you know, Suboxone, IOP. What really matters is the ability of the clinician to form a therapeutic alliance with the individual and for the clinician to instill in the patient the expectancy of hope. So I do believe that abstinence is the preferred method, but I would rather celebrate incremental change in a positive direction than to shut somebody down and help them lose all hope of ever improving their lives, you know? So I think for some patients, the cold turkey quit is the best. For other patients, a more incremental approach, especially to tobacco. I've been trained in a motivational approach to tobacco cessation by the staff at the Maryland Quit Now state quit line, led by Dr. Carlo Di Clemente. And, you know, if patients don't feel like they can make 100% quit commitment and they're going to blame and shame themselves if they fail to meet their goal, sometimes it's best to get them to meet an incremental goal, like cut back to no more than 10 cigarettes next week. And when they go from being a pack a day to a half a pack a day, or from a half a pack a day to 3 cigarettes a day, it's not that I believe 3 cigarettes are safe. It's not that I wouldn't tell them that I don't believe, you know, I don't believe that 3 cigarettes are safe, but I'm going to congratulate them for making a change. And when patients see that they can make a change, they can achieve a goal, then you can help them get their fingernails in the crack of the problem and open it up and go a little bit farther next time. Now, I don't believe that drug treatment programs should allow, I think they should be smoke-free facilities, but the program that I work with allows patients to go outside and smoke. So I think if that's a problem for the caller, trying to get, you know, trying to negotiate with treatment programs that want complete abstinence, maybe there's someone at your state, single state authority, your statewide office for behavioral health, or your state tobacco quit line who could help you negotiate with the treatment program. Did you have another question?
Yeah, I sure do, and I just wanted to let you know that the caller from the first question did reply, and they said that the explanation was very helpful. So,
good.
Okay, the next one we have here, and we've had a couple more that have come in, so I don't know if you want to keep taking them or if you want to finish later. But
let me do one more, then we'll finish the rest of them at the end, just
okay,
to make
great.
sure I get all the comments.
Yeah, sure. Okay, so the next one is, who assumes patient responsibility after a referral is made? Does the primary care provide integrated care with the referral agency?
Well, this one has always disturbed me. I worked in primary care a good part of my life. I didn't work in addictions treatment and administration until the late 90s. You know, when somebody has diabetes and you're trying to get them to manage their blood sugar levels at an optimum level, and Christmas holiday comes around and they go to a party and they eat a bunch of cookies and cakes one night and they spike their blood sugar, you don't slap their hand and say, no more insulin for you. But we've always tried to punish and shame people with substance use disorders for compliance or not compliance. And the previous slide, one of the previous slides mentioned that failure to initiate and stabilize recovery is often viewed as the failure of the individual rather than the flaws in the design or execution of the referral protocol. Plenty of providers say, okay, here's a referral card. When you get your life back together, come back and see me in primary care. And I work with homeless men in downtown Baltimore who are transitioning from incarceration or drug treatment back to the community in a residential job training program. And I can tell you that many of these patients, it's an abstinence-only program because it's not a drug treatment program, it's an employment program. But some of these patients relapse and a couple have overdosed and died. A huge risk for these men is that they're suffering from the chronic illnesses that affect other men in their 40s and 50s. We're detecting, I work with nursing students who do health assessments on, and health promotion with these men. And we cannot forget that they're, you know, do you want to focus so much on the opioid addiction that you fail to pick up that they've got prostate cancer and they die, or they have a heart attack and they die, or they have a stroke, or they go into, you know, kidney failure, or their diabetes gets their lower extremities cut off. So I think I need to hear the question again to make sure I answered all of it. Whose responsibility is it to manage the referral?
Right.
And so I think it's all of our responsibility. In recovery support services, perhaps the primary care, depending on the relationship between the patient and the family, you know, if the patient comes in with their spouse or their child, maybe the spouse or the child helps remind the patient about the appointment, or notifies the doctor if the appointment is not kept, or helps make transportation and child care arrangements so that the patient can go to the appointment. So, you know, it kind of takes a village to take care of these individuals. And for so many years, it was seen as not being within the purview of primary care. And that's what I'm going to get into in the next part of my discussion. So should we hold the rest of the questions until I go through the second half?
Sure, yeah. Why don't you go ahead and continue,
okay.
And then whenever you're done with the content, we'll read the rest that have come in.
Right, and so I think some of the literature that went out said that this was a 1-hour presentation, but you and I agreed that it would be a 1.5 hour. So if people can't stay till 3:30, they could watch the recording later. but I plan to finish up in the next few minutes, and then I'll hold questions until 3:30.
That's great.
Okay, so I've showed everybody all the red boxes, but now I want to move to the yellow boxes at the bottom of the model. And these yellow boxes in the model represent the 4 major service categories in the substance use disorder services continuum. So the red boxes above that are blanked out now because I want us to focus on the yellow ones, they were recovery management components, but now we're going to focus on the substance use disorder continuum of care components. The first one being prevention. So let's see. This service continuum here starts with prevention on one end and goes to through treatment, early intervention, addictions treatment, and ongoing recovery care, continuing care and recovery support. So prevention includes services for individuals and populations who have not yet experienced the onset of the disease. So, you know, these are people whose screening test would be considered within normal limits. And fortunately, there's much more of these people than the ones that you would identify as having serious substance use disorders. I implemented an SBIRT project in downtown Baltimore at a university-affiliated primary care ambulatory care clinic, and I expected a larger proportion of the patients to have higher problem severity. But just like that SBIRT triangle shows, that majority of the patients that you will interface with if you implement an SBIRT project will be people who have not yet experienced the onset of the disease. And so prevention services include not just the primary care provider, but also collaboration with other systems like child welfare, VA, veteran services, stigma reduction activities, and prevention services for families and siblings of people that are in treatment. So a lot of times we focus on the person who's in treatment, but the people that are in their network of family and friends can benefit from prevention services too. And there should be a prevention services coordinator in your community, in your county or city. So now we're talking about early intervention, and early intervention is for people who've developed risk or developed the disease but haven't been detected yet. And so it includes screening and early detection, intervening with those people, because it really not only does it make sense clinically to identify someone and then not intervene with them, but it's also a liability risk. If any condition that you identify, you know, if you fail to address that problem, even if you didn't administer standardized screening instruments to conduct your SBIRT with, like even if you chose, you know, you're not ready to do the audit or the, you know, single item drug screen and 3 frequency quantity questions or whatever. But if you've identified substance use disorder in your patient and you fail to intervene with them, that's kind of, you know, that's not the best standard of care, community-based care. And if it were any other disease except the disease of addiction, which is stigmatized and scorned, that would be considered malpractice not to follow up on positive lab values, for example. Things that you observe like track marks. So anyway, early intervention includes screening, early detection, outreach services, and pre-treatment recovery support. So this helps answer the previous caller's question too. If people aren't ready to commit to making a change, they may still be using substances, but they can still benefit from some services that you may have to offer, like housing, family counseling services, transportation. the whole thing is so overwhelming to them that they can't even picture making a change until somebody like a trusted healthcare provider instills the expectation of change in them, that the provider believes the patient can change. That goes a long way to making the patient believe that the patient can change. Okay, so the next stage in the recovery substance use disorder services continuum would be treatment, specialty addictions treatment. And within this comprehensive continuum of care, specialty addiction treatment refers to the menu of treatment resources like medically managed withdrawal services, what people have known as detox, outpatient or intensive outpatient, pharmacotherapy like medication-assisted treatment with methadone or buprenorphine, partial hospitalization, short or long-term residential services, or concurrent mental health treatment for individuals with co-occurring psychiatric disorders. But we can also consider alternative services and therapies like acupuncture, meditation, and yoga. And the fourth component of the substance use disorder services continuum is ongoing continuing care and recovery support. And I've touched on this already. The child care, transportation, housing, life skills training, employment readiness, legal consultation. So only about a real small percentage of adolescents and adults who complete drug addiction treatment or alcohol addiction treatment actually receive post-treatment continuing care. So recovery management models of continuing care include post-treatment monitoring and support that's provided to all clients, not just those that were successfully discharged from treatment. So the role of the primary care provider is to provide monitoring and support for the substance use disorder, just like they would for the cardiac condition or the oncology problem or the endocrine problem or the orthopedic problem. And whether they successfully completed their treatment and achieved abstinence, they're still your primary care patient, and you're still responsible to care for them with all of their other needs. And when you can treat them with unconditional regard and provide a supportive, welcoming environment and build trust with them and meet their needs where they are, housing, marital therapy, parenting support, you might just find that they're going to be willing to work with you on eliminating the tobacco problem, or they've given up heroin but they're not ready to give up marijuana. They might just work with you on the kinds of things that you want to see them resolve. So now I'm going to show you how the model all fits together. In the traditional delivery of SBIRT services, there's not a real solid conceptual relationship between SBIRT prevention services and the pre-treatment recovery, pre-recovery identification and engagement, the first red box on the left. And that's because prevention messages are delivered to individuals who screen negative. And when that happens, the screener congratulates the individual who has a negative screen for their current abstinence or their current low-risk drinking habits and encourages them to keep up the good work. Next, in early identification, there is a very sound, conceptually sound relationship between the SBIRT early intervention or screening service and the recovery management model concept of pre-recovery identification and engagement. Brief intervention messages are delivered to individuals who screen positive, but they have problem severity that's relatively mild. And brief intervention is most appropriate for those with problem drinking or harmful hazardous drinking, but not those with more severe problem severity like people with alcohol dependence, drug use, or drug dependence. The brief intervention messages are designed to help patients drink within the daily, weekly recommended limits and to reduce their risk and consequences of substance use, because we all know there's some patients for whom no safe level of alcohol consumption is. Underage children, pregnant women, people who are driving or using machinery, and people whose medical condition would contraindicate any use of any substances. Now, let me see if there's one more thing I wanted to add to that piece. Oh, back to early intervention. So you've screened them and their screen is positive. A good primary care provider that really wants to understand the best way to manage these patients would then provide a little bit more assessment to get a real understanding of the problem severity. It's not enough just to, you know, ask a couple of questions that you get a yes answer to or a score to, like an audit score, without then going on to look at like use of other substances beside alcohol, complications related to their consumption, how it's impacting their other medical problems. So there is a bit of a assessment component within SBIRT that is needed to help determine whether the screen is positive mild or the screen is positive more severe. So here's an example of where within the SBIRT model, referral to treatment was indicated because of the screen being positive and the problem severity being more severe. So in the traditional delivery of SBIRT services, there's a very conceptually sound but tenuous relationship between SBIRT early intervention or screening and recovery, initiation, and stabilization. And the referrals to treatment are delivered to individuals whose problem severity is relatively severe, and they involve clear messages from trusted healthcare professionals intended to help patients understand the seriousness of their problem and their need for special treatment within the context of their overall health status. Encouragement and support are critical, and the patient should be assured that treatment is generally effective, although considerable effort may be needed on their part. So when I mention trusted healthcare professionals, I'd like to put a plug in for nursing right now. Part of my role at the University of Maryland is to infuse throughout our curriculum substance use content and safe prescribing practices. So, you know, a lot of people one of the barriers to implementation of my SBIRT project was to get nurses in that clinic to understand that counseling patients about their screening results is within the role of nursing. It's within their scope of practice. But some places traditionally refer patients with positive screens or patients who use substances to social work. And, you know, substance use disorders are complex disorders with lots of causes, and they require, you know, an integrated, multidimensional approach to be successful. So like we mentioned earlier, referral to treatment is the least studied of the three components, and I want to thank Dr. Dawn Lindsay for opening my eye to that. I have two eyes to that. And so I mentioned earlier that you have to look at the type of referral. Was there a warm handoff or facilitated referral, or did somebody just say, here's a card, call these people? If you've ever tried to call those people to make an appointment for somebody, you'll see the kinds of barriers that patients encounter, even if there wasn't a backup or, you know, a wait list. And are there access barriers to specialty treatment? Is there adequate treatment capacity, wait lists, geographical access problems? Do patients need transportation assistance? Do they have medical insurance? When I worked for the state of Virginia, I knew of patients who had to drive 3 or more hours each morning to get dosed with methadone and 3 more hours to go back home. So to consider somebody to drive 6 hours every day to be dosed with methadone because there's geographical access problems and lack of treatment capacity is a pretty sick, broken system. But part of the role of nurses and other professionals that want to see primary care integration be successful is to work with the state agency responsible for treatment capacity and management of statewide services to try to make good linkages between their practice and to facilitate patients getting referrals to treatment. But then, did the patients get adequate follow-up? And this goes to the previous caller's question, who's responsible for making sure that a referral was kept? And so, you know, even if a referral's made, if we don't know whether the appointment was kept or not kept, or we don't know whether their frequency or quantity went down, and we haven't followed them for 3 months, 6 months, or 12 months, you know, we don't know what the real outcomes are. And we don't know whether patients received adequate reinforcement about the referral. Like when I was a public health nurse, we had to call patients about a week before the appointment, help them get transportation set up, call them the day before the treatment, see if they were still committed to going, call them the morning of the treatment, see did their transportation fall through. And that wasn't trying to put patients in substance use disorder treatment. That was just to get people to places like pediatric appointments in primary care. It's probably even harder to get them to follow through with the commitment to keep an appointment for drug and alcohol treatment. And you can reinforce that the first appointment doesn't mean you have to make a commitment to treatment. You don't necessarily have to change your substance use. It would be good to have another professional just do an evaluation on you. You frequently send patients to cardiology or orthopedics for a consult assessment. And then the patient can decide from there whether they want to follow through with treatment services. And then the people who didn't keep the first appointment, they need a re-referral. Like sometimes the first one didn't stick, but the second or third one would. And we don't know when we're doing outcomes of evaluations of SBIRT projects whether people were involved in self-help or, you know, they used AA or NA, or whether they had adequate peer recovery support. And we're not sure how to even measure success with quote marks around it. Like, what about if they entered treatment but didn't reduce their use? You know, they might still be using substances, but they could have gained a lot of valuable help by following through with treatment services in other domains of their life, psychiatric or social, for example. So what I'm proposing to you is that traditional SBIRT, as we've known it for these past several decades, is really a job half done, and that the negative outcomes reported in the literature may be the result of both program evaluation and outcome measurement issues, but perhaps more importantly, the failure on the part of primary care providers to adequately address the third and fourth components of the recovery management model, the two red blocks on the top half of the model. So here's the model again with both halves of the recovery puzzle put together. This is the reconstructed model in its entirety, with recovery management being the other half of the SBIRT recovery puzzle. I'd like to ask people, what What if behavioral health problems and specialty referrals were addressed like other types of acute care, chronic care conditions? And how do we treat people with, you know, the good kind of acute care and the good kind of chronic care problems to have differently than the patients with substance use disorders? So if behavioral health problems and specialty referrals were addressed like other types of healthcare problems, we would treat acute substance use disorders like intoxication, withdrawal, or overdose the way we treat other acute conditions like broken arms, injuries, or acute illnesses. And we would facilitate appropriate referrals upon discharge from the emergency department. I'm going to repeat that one. We would facilitate appropriate referrals upon discharge from the emergency department. If we treated the chronic disease of addiction the way we treat other chronic illnesses that we see in primary care, we would screen and refer individuals to specialty care the way we do for other specialty referrals like cardiology, orthopedics, neurology, endocrinology. And the primary care providers would coordinate patient care across multiple providers and multiple systems, and we would remind patients about their upcoming specialty appointments. And we would track their progress in treatment by obtaining copies of their medical records from their specialty treatment providers. When I go to see my primary care provider, he has a copy of all of my specialty stuff, you know. He's got the results of my mammogram. He's got the report from when I went to visit the orthopod in my primary care folder because somebody thought to send my primary care provider a copy of my specialty treatment. And maybe the primary care provider thought to get me to sign a consent form and request that information. So if we treated substance use disorders like we treat other disorders, we would track their progress in treatment by obtaining copies of their medical records, and we would review their treatment plans with them and teach them about disease self-management like we do about how to manage their diabetes or their hypertension, how to reduce their risk. And we would reinforce their recovery efforts, no matter how small an incremental positive change was. And if we treated substance use disorders the way we treat other disorders, we would learn, primary care providers would learn more about the disease of addiction, and we would provide medication-assisted therapy as needed, like Suboxone or other, you know, buprenorphine products. If we treated substance use disorders the way we treat other disorders, we would stop using stigmatizing language like addict and alcoholic, and we wouldn't call urine and blood tests clean and dirty. We wouldn't say the patient was clean because he'd stopped using substances, because that would imply they were dirty when they were using. We would continue to treat their comorbid medical conditions before, during, and after their specialty addiction treatment. And we would not tell them, go get some treatment and come back to primary care once you're drug free and have gotten clean. We would encourage and support individuals over the full course of their lifespan. So in conclusion, I believe that the SBIRT Plus recovery management model provides rationale for enhancing outcomes for substance use disorder interventions delivered in primary care settings. I think it provides insight into why SBIRT alone, or what I'm calling traditional SBIRT, may not be effective for more serious substance use disorders like drug use and alcohol and drug dependence. Importantly, the SBIRT Plus recovery management model will help healthcare providers in all treatment settings, help individuals in recovery lead safe, healthy, meaningful lives in the community, surrounded by the people who love them and encourage them to succeed. So that's all I have today. If there's any nurses out there, I'd like to introduce you to the International Nurses Society on Addiction at www.insud.org. We are the specialty organization for all nurses who work with patients with addiction, not just the ones who work in specialty addiction settings. So you primary care nurses are welcome, hospital nurses are welcome, because really patients with addiction appear in all treatments, all healthcare settings and community settings. And all of you would be welcome within our society. And now I would like to answer the rest of the questions.
All right, sure. Just real quick before I get to the questions, there were just a couple of statements. The one recently was just saying what you were saying about words. Words are powerful, and we can use them to heal or harm, so that was very wise that you said that.
Thank you.
And let me go back here. So where we left
One thing about that, if we treat a plant like it's a weed, it will be something that we don't like, and it's not, you know, it's not a good thing. But if we treat it like it can be a beautiful flower, it can grow and become a beautiful flower.
Exactly. And whenever you brought up nurses, there were a couple nurses that were like, woohoo, nursing. So we definitely have some nurses on here today. But getting back
to that window, sorry, Steph.
Oh, that's okay.
See the word CARN after my name? That's Certified Addictions Registered Nurse. So you can find out more about how to become certified in addictions registered nursing. I'm not a nurse practitioner. My Doctor of Nursing practice is in public health. But if I were a nurse practitioner, I would also be eligible for the Certified Addictions Registered Nurse Advanced Practice. So INSA offers the CARN and the CARN AP credential, which can be very helpful to you, and we have annual educational conferences that you might be interested in. The next one's coming up in October in Orlando, so you can take your kids to Disney World.
There you go. Okay, so let's get back. There was about 5 other questions that came in. So the first one would be, when we look at shifting the focus from the service environment to the client's natural environment, what consideration do we give to the client's natural environment not to be conducive to the client's recovery? Do we encourage the client to leave his partner?
Well, that's a question that is best addressed in treatment, either psychological treatment or addictions treatment. You know, we're not asking primary care providers to go step broken legs. We're not asking the primary care provider to necessarily go birth babies or perform cardiac bypass surgery. We're only trying to get you to help the patient get to the specialist that they need to be with. So if somebody's problem severity is so bad that the social environment that they're surrounded by is interfering with their recovery process, that's a good time to get a consult at least from an addiction treatment provider who can help you determine with the patient's help whether that's a good move for them or not. And for some people it will be, and for some people it won't be. That's why you can't just get somebody to be abstinent from alcohol or drugs without addressing all of the dimensions of their life. Their social dimensions, their occupational dimensions, their intellectual dimensions, their social dimensions, their spiritual dimensions. We have to address people in a holistic manner, in a way that addresses all of their different problems. But just finding out how bad their problem severity is, you know, is not necessarily in the role of the primary care provider. That's where you need a specialist referral just to do diagnosis and level of care determination. People who have that disruptive home environment, maybe domestic violence or other drug users in the home, that would be a dimension of placement criteria that would be an indicator that somebody might do better in residential treatment than somebody with the same condition in an outpatient setting. You know, so we're not asking primary care providers to do level of care determination. We're asking primary care providers to say, I think this person's level of problem severity is high enough that I need to consult with a specialist about how to best address the needs of this person. Okay, next question.
All right. The next one is, it was interesting to hear there's about 40-plus years of evidence for the effectiveness of SBIRT, and currently SUD treatment and care is an essential benefit. What are some of the reasons or challenges that have prevented a wider use to date?
Okay. Don't take that essential benefit for granted. I have a letter from Congressman Sarbanes of Maryland. He just wrote to me yesterday because I called his office to say that I have problems with the proposed repeal legislation because the current legislation, I forget what it's called, Graham, the new bill that's being considered within the next week because Congress wants to deal with the appropriations and everything, and they can't get the bill passed with 50 votes until after the end of the month. They've got to deal with budget reconciliation. I think I've got that beat. I think that's what the term is. So we fought really long and hard to get the Mental Health Parity Act in place. And even though it was passed, nothing gave it teeth until the Affordable Care Act came along and required drug treatment to be one of the essential services, 10 essential services. So the current legislation proposes eliminating the 10 essential services requirement. And it also decimates Medicaid. And part of what's made the opioid epidemic is so serious right now. It's growing at such a fast pace, but I can't imagine how fast it would be growing if we didn't have Medicaid expansion. And states that have expanded Medicaid have lower mortality rates than states that have not expanded Medicaid. So what was the question, Jess, that they, what can we do?
Yeah, well, it just said, what are some of the reasons or challenges that have prevented a wider use to date?
Okay. I started training people in the use of the audit back in the year like 2000 or 2001, and I implemented an SBIRT project as my doctoral project, and I realized quickly how difficult it is to implement SBIRT. You have to have a lot of policies in place. You have to figure out how to document in the electronic health record. You have to figure out, people don't want, already your primary care provider is spending less than 13 minutes per patient, and then the lack of referral resources is important. I would encourage, what's Tracy's last name? Dr. Eric Goplerud and Tracy
McPherson.
Yeah, Tracy McPherson. If you could type that, their two names into the chat box. I can't see the chat box, but
yeah, sure, I can do that.
They have a document out that's something like addressing the facilitators and barriers to implementation of SBIRT. And so while I understood clearly how to screen and how to do motivational interventions that would help people reduce their use or refer to treatment, I really had to work for a long time to overcome some of the implementation barriers, and I found Goplerud and McPherson's publication on barriers and facilitators to be very helpful. And there's another document by CASA, the Columbia University, CASA, has an SBIRT implementation guide that's very helpful. I'm willing to have people send questions to me at the email address on this document. And I want to reemphasize that we can't let the Affordable Care Act go down the drain, because 30 million more people will be without insurance. Medicaid will turn to a block grant, and the essential benefits will be lost. And that's only a piece of what I know about the new legislation. I haven't really read the new bill yet, but I published last month an article in the Journal of Addictions Nursing called Socialized Risk and Privatized Profit, What Addictions Nurses Need to Know About the Potential Repeal of the Affordable Care Act. And if anybody would like to look that article up, or need the reference, or if you don't have access to a library, I can try to get a copy of it for you.
All right, awesome. Thank you so much. And I did, just so everybody knows, I did put Tracy and Eric's names in the chat panel, and then there's also a link to not that exact article that you were talking about, but one that is on adolescent SBIRT, and integrating adolescent SBIRT through social work and nursing education.
Nice.
So I did stick that in there too.
And the emergency nurses have, the ENA, the Emergency Nurses Association, have good materials for implementing SBIRT in emergency departments.
Yeah. Okay. The next one we have here was asking about your model. And they said, is this an example of the wraparound model that is a proven holistic ethical medical care foundation for clients moldable to all aspects of life?
I don't know if it's, all right, I took the substance use disorder continuum of care and did a lot of reading about, William White has some excellent books and articles on his website. And the source, one of them was the source of information for this model. I don't think the model is known by a whole lot of people, but recovery management is known by a lot of people. So the question is this model, is this what provides the wraparound services that somebody said was holistic? Or the answer is that providing sustained recovery support and long-term recovery maintenance includes providing wraparound services like child care, transportation, housing, educational support. Because again, recovery is not just the absence of substance use disorder, of substance use. It's achieving positive outcomes in all these other dimensions. So people have to, get their health care straightened out. They have to get their, their legal situation resolved if they're ever going to hope to get a job. The men that I work with, some of them are college graduates, some of them don't have their GED yet. So providing a GED to somebody is going to help them, and employment support will help them get a job, which will help them have a meaningful life in the community. And have the resources that they need to provide housing for themselves and their families. So I think this model that I'm proposing is a holistic model, and I think because I'm a nurse, I've looked at it in a holistic way. Plus, I teach nursing theory to doctoral students, so I kind of wanted to evaluate this clinical practice problem from a theory analysis perspective. But I don't think it's the exact model that you're referencing to. I think the models would be similar.
Okay, great. So we just have a couple more. You've mentioned you worked in primary care. What are your thoughts around resistance by many primary care providers to address substance use disorders? I've heard some even will refuse to complete a quick CAGE or audit screening tool.
Well, when I first tried working in SBIRT in 2000, we had doctors tell us that they only wanted to administer the CAGE and they would only do it if it had half as many questions. So the physicians are not necessarily keen on the idea. Now, I have a physician across the street with whom, you know, I work on projects with, and he's involved in pre-licensure education of physicians, and I'm involved in pre-licensure education of nurses, and somebody else from our university is involved in pre-licensure education about addiction among pharmacy students. And I lecture at the dental school where they have a substance use disorder course that's mandatory for second-year dental students. So I think the people that are already practicing, they're going to be a tough nut to crack. But the people that are coming out of schools, if universities make a serious attempt to change and make it acceptable among people, once they get out of medical school, it's going to be hard to change their attitudes. The Medical Society of Maryland, it's called MedChi. I think it's M-E-D-C-H-I, I'm not sure. Dr. Ingvild Olsen did a report, a survey of physicians about their willingness to implement medication-assisted therapy with Suboxone. And, you know, the stuff that came out of their mouth was not pretty. They don't like these patients. They don't want to see them in their waiting room. They don't think they're qualified to intervene with these patients. And the funny thing is, you're probably already seeing patients with substance use disorders. You just don't know it because you didn't ask. But if you found out, you shouldn't scorn them and shame them. And I say about medical providers who don't like working with patients with substance use disorders is kind of like my children are grown now, but certain teachers that they may have had, some really loved working with children and some really didn't like children. And I feel like if you don't like children, you should get out of teaching. And if you don't like working with patients that have substance use disorders, try finding somewhere where you don't, where you aren't going to encounter them, but really you're going to encounter them anywhere you go. So I've been involved in trying to get primary care practitioners to do a lot of things, from reporting communicable disease to administering childhood immunizations to becoming certified for medication-assisted therapy through OBOT, office-based opioid treatment. And I've tried to get primary care providers to implement SBIRT, and all I can say is I'll say the same thing that I say about physicians not wanting to treat patients with opioid use disorders in their treatments, in their offices. If you don't want to provide medication-assisted therapy, get out of the way and let the nurse practitioners do it. So I was very involved in legislation to get nurse practitioner prescriptive authority for opioid treatment. And I'm really glad that that legislation passed last year. I think if you can't get your primary care physician to be interested in this, try to get a nurse trained in this, because the nurse will make it happen. And then also, there's a couple of I don't mean to sound like I'm bashing on doctors either, but there's a few doctors that are very, very good in this area. And I think if you're a clinician, a nurse, a counselor trying to talk to a physician about implementing this in their practice, you're not going to be as effective getting them to change behavior as another physician might be. So try to find a champion who will be willing to work with them, to try to encourage them. And it never hurts to use motivational enhancement communications. The more you try to push somebody who's not willing to change, the more they're going to resist. And then the more they resist, the more compelled you feel like you have to push back. And then the two of you get into a, a confrontation denial trap, and it turns circular and nothing ever gets done. So I would suggest maybe getting another SBIRT person to communicate to them, because once people see, they like to think that these patients are difficult to deal with and they don't have positive outcomes. But if we can demonstrate positive outcomes, they may be more willing and even happy to implement and take some of the burden off of them, because they've got paperwork burden and group practice requirements to see X number of patients per hour, and explore the different service delivery models. SAMHSA's SBIRT consultants can help you with that, and I'll be happy to try to link somebody to an appropriate expert if they need help with that. It's 3:30. Are we going to time off, or there was another question, wasn't it?
Yeah, there's two more. I have no problem staying on, and it looks like a majority of folks are still on. So if you want to finish up the last two, that's fine with me, if you have time to.
I'd like to, but the people
Sure.
who've asked questions already, if you don't mind providing feedback to Tracy about whether that adequately addressed your question or not, I'd like to not leave you hanging by missing part of your question. So, all right, next to last question is next.
Okay. So I made a note whenever this question came in. It was when you were talking about referrals. So they had asked, is this where IT tools and cohesive collaborations could come in? And instead of competition, could it be synergistic collaborations in the primary healthcare institutions?
Did you say IT? Like in
Yeah. She said, is this where IT tools and cohesive collaborations come in?
So the extent to which you can get your electronic health record to provide reminder recall and to flag charts of patients who were referred in the past to have a pop-up next time they come back for the nurse or physician to inquire about how the referral went, or to see if there's been improvement, or to remind the provider to ask the person about how their treatment plan is coming along. Those IT can be very helpful. One thing that's really critical is that healthcare providers generally know about HIPAA, but they don't know about 42 CFR Part 2. So you have to kind of educate SBIRT providers about the portions of privacy and confidentiality that in 42 CFR that go beyond the requirements of HIPAA. Like, for instance, if some of the issues that we had to overcome at the place that I was at was that they didn't want to put substance use disorder on the problem list, because the health record was going to generate a problem list on the discharge summary, and some of the patients needed a discharge summary to take to their boss to document that they were in fact seen at the doctor's office that day. So, or like the patient consents for you to release their information to the drug treatment program, but the patient may not want you to release the information to their cardiologist, for example. So if somebody asks for records to be transferred, you have to know whether your consent to release should include specifically consent to release information about their substance use. And if not, then somebody has to go through and redact all that information out of the chart before, your medical record people might not know that. So what was the rest of the question, Tracy? Jess, that IT and...
Yeah, it just said, is this where the IT tools and cohesive collaborations come in? And instead of competition, it can be synergistic collaborations in the primary healthcare institutions.
Absolutely. Like sometimes you have to compromise. The program that I was involved in, the nurse manager and the medical residents, the medical residents were like, we're not going to get involved in it. We have no problem with you implementing SBIRT as long as we don't have to do it ourselves because we're too busy. So the nurses did the screening and brief interventions for alcohol, but the particular clinic's protocols required that any substance use other than alcohol and tobacco had to be referred to a social worker. And in reality, appropriate trained nurses can handle. SBIRT is not really delivering, when I say it's early intervention and providing a brief intervention, what it really is a better way of communicating with people that have substance use disorders. It's a way of communicating with patients about that problem in their life the way you communicate with them about other problems they have in their life. And nurses for 20 years now have been the most trusted profession according to the Gallup poll for many years, So, but some nurses who were not trained in their pre-licensure program might not be confident, in their ability to do that. So there's a whole lot of different integrated care models. I think it's better if nurses and physicians know how to both screen and do brief interventions, because if you hire an addiction counselor to come in 2 days a week to do this for you, then they're not going to be there one day and you're going to need some help and you won't know how to handle it, Or they're going to go on vacation and then nobody's going to get screened and intervened with while they're on vacation. Or like the social worker at the clinic that I was working with had medical leave for an extended period of time, and if I wanted to complete my project on time, I needed to go in there and be the counselor because I'm a certified addictions nurse. They allowed me to talk to people with drug use problems. I see no reason why an RN should not be able to communicate with patients with drug use problems, but that was the barrier that I encountered in that clinic. And I think it's good to do an assessment of barriers and facilitating factors before you try to implement this, and do a lot of planning. Don't say, okay, here's an audit, we're going to start this next Monday. No, there's a lot of planning and collaboration and network building and referral source development and checking to make sure phone numbers are correct and that you've got flyers to give to patients. But it's important that everybody involved in their care kind of normalize the treatment of this disorder. People with substance use disorders are typically scorned in hospital settings or clinics. So if we're scorning people, they're not going to feel compelled to want to make the changes we want to encourage in them. So, yes, an integrated model. Of course, it's not going to be one person pulls this off. It's going to require a whole team being on the same page.
Right. And before we get to the last question, I just wanted you to know that the folks that had asked the questions earlier have all said thank you for your thoughts. It was a great training. Your response to the question and the subsequent discussion was extremely helpful.
Good.
And thank you for your thoughts around PCPs and resistance to screening. It was very, very helpful. So
good. Thank you.
Okay.
I want to thank them for showing up today and giving me something to be excited about Recovery Month for. So
absolutely. All right, last one.
Mm-hmm.
Many doctors I speak to say that they do not want to provide these services because there's insufficient reimbursement. Our billing codes in New York State require at least 15 to 30 minutes to be reimbursed for the BI, which most PCPs do not have. Any advice for how to get buy-in from doctors since they may struggle with the reimbursement aspects?
Let me just say that I was on the committee that worked to develop the HCPCS codes for Medicaid back in, let's see, early 2000s. And I never understood why physicians want to bill separately for this service. So lady comes in and she's, you know, continuing to gain weight and continuing to spike blood sugars. And upon inquiring about diet and consumption of junk food, find out that she's been drinking 2 liters of Pepsi a day and eating potato chips all day. Okay, so doctor says, you know, I'm really concerned that your consumption of sodas and potato chips is making it difficult for us to control your blood sugar. Do you think you could cut down on one of those or both of those, you know, maybe go from 1 2-liter drink per day to maybe 2 8-ounce drinks of soda per day, and maybe replace at least 2 of your snacks per day with a healthier alternative, you know? And doctor doesn't get reimbursed extra for telling a diabetic patient to stop using soft drinks and junk food, but because addiction was always treated in a separate system of care, like when the Vietnam vets came back addicted to heroin and the opioid treatment programs started popping up and they were federally regulated, and there were no specialists in addictions other than people who were in recovery themselves. You know, it's been treated differently, and so we need to mainstream the management of substance use disorders into general care the way we treat other substance use disorders. Now, I'd say, you know, bill it as a more complex service, or, you know, more intensity. You know, there's a low intensity visit and a high intensity visit or something like that. But, you know, would I fail to do a pap smear on a woman that needed it, or would I fail to recommend mammography, or don't I recommend colonoscopy screening? To me, if you're not doing all of the recommended screenings, especially the ones that are recommended by the Joint Commission and the National Quality Forum, then I think you're failing to meet a community standard of care. And maybe a real effective way would be to work through accreditation programs, or, you know, magnet status at your hospital, or, you know, and Medicare. I think Medicare, I'm not skilled to answer this question with great authority, but I think asking about tobacco and alcohol might be a Medicare requirement. So I think there's ways that, and I'd be happy to think out loud with somebody if we scheduled a phone call one day to think about how programs can work with regulatory bodies to exert a different kind of pressure on providers that may not have the intrinsic motivation to implement these services. I think that.
Yeah.
Okay.
That is good. So there have been no other questions that have come in, just besides folks saying thank you. There was someone who asked if you were going to be doing any other webinars in the near future, because this has been very informational for them. I told him I wasn't sure, but I could ask you, and I didn't know if you were doing any webinars for anyone else in the near future. But everyone has really loved this discussion today and appreciated all your knowledge.
So if you want me to come back, you have to give me good evaluations, and then Irita will ask me to do other work. And if you want to come to an INSA conference or something like that, I'll be presenting about nursing education and substance use disorders. Maybe, I don't, are you, Jess, is Irita looking for other topics besides SBIRT related?
Yeah, I think we will be in the future.
Yeah, so I'm really flattered that everybody appreciated this. This is sort of my my passion in SBIRT, you know, and I'm really happy that it's helpful to people. And I think it answers that question, why does SBIRT not get the kind of implementation or adoption of SBIRT, because, and why are the outcomes not as good as they could be? And I think I would hope that future research would evaluate comparing the outcomes of traditional SBIRT to people who got traditional SBIRT Plus recovery support services, and demonstrate, like I've proposed this theoretical conceptual framework. In a real world, we'd have to test this to see if it really would improve the outcomes, but maybe it will. And I'd like to, yes, I'd like to be involved in future training efforts. So thank you.
Yeah. All right. Well, again, I want to thank everybody for their participation on the webinar today. And thank you again to Dr. Fornili for such a great webinar.